for joining us for the 7th installment of the COVID-19 Think Tanks. We've been lucky enough to put this on every Friday since this all kind of started, and we're excited to keep this going as just a best practices, lessons learned, way to learn about everyone's rapidly evolving projects. So to do a little review of what the Society for Health Systems are, who's putting on this think tank, the main mission is to improve lives through better healthcare delivery, and we're doing that in a multitude of ways, and one being this think tank. We also have a conference happening every February where everyone presents their work and we can all learn and hopefully improve from each other. So there's a multitude of communities of practice within SHS. We have education, academics, clinical students, young professionals who are putting on this think tank and experience. You can.
Good afternoon, guys. Can you hear me?
Yep, we can hear you. Are we okay?
Yep, you can keep going.
All right. So we have a multitude of communities of practice, and those are just getting like-minded individuals in a group to, again, make healthcare delivery better. So if you're interested in joining any of those communities of practice, please reach out to either Erin or I, or join on the link on the bottom. We'll be sending out this slide deck as well as the recording after this presentation, and we'll look forward for you guys joining us next week. Again, we have all of these recorded, so you can go back. If we talk about something today that we've talked about in previous recordings, feel free to jump back and listen to what you might have missed. We also want to promote IISE Connect. They have a crisis resource community within IISE Connect where we are posting the recordings of these think tanks as well as other people posting resources that they've found helpful so far. And with that, I'm going to pass it off to today's presenters. Very excited to have Dr. Tafe and his student Vishnu talking about team-based risk-adjusted staffing during a pandemic. We then will follow that by Katie Smith talking about helping leadership with their decision-making moving forward and using COVID-19 hospital models. And then Jordan Peck will be talking about using control charts to help us return to normal. So we have all of their emails attached in here. You can ask questions via the chat, and either Erin or myself will ask the question to the presenter, or you can take yourself off mute and ask your question yourself. So this is a very open discussion, and we're looking forward to today's talk. So with that, I'm going to pass the controls over to Dr. Tafe to present his slides.
Great, and that's Kevin to all of you. Thank you, Allie.
Yep, sorry.
Yeah, no, and those bad habits, just can't break them, right?
Yeah. So in order to share, you just have to click the third circle from the left on the bottom there, the arrow up. Okay.
And so I'm also just impressed that you guys have put this together 7 weeks straight. I went back and watched a few of the ones that you've had. That's been great. I'm glad that the interest has continued, and we have an opportunity to share some of the things that that we've been working on. So, as I put it into slideshow mode, I just want to make sure you can still see it. Yes.
Yep, okay. We can see it.
Yep.
So I guess now, probably about 5 weeks ago, we were approached by Prisma Health in the upstate of South Carolina to address an issue that they were debating on how to restaff their anesthesia teams across their facilities. One of the things that they've enjoyed over the years is really just complete flexibility in in how they get it. They pick their shifts, and they enjoy being able to rotate around to different facilities. Um, but our collaborator, Dr. Hand, really was afraid this is not the right way to go, and he was trying to justify why that is and how much could there be the potential for an increased level of uh, infection if they don't change their staffing policy. Um, Now, especially in our part of the country, the outbreak of cases has been fairly low, so we haven't had um, any serious surges in cases in the upstate. So, um, I guess his worst fears were not played out. So I think we're thankful for that. But the 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 research has still been enlightening to them, so that moving forward, what are we going to be able to do? So as I uh, move into, I'm really not going to cover some of the things that many of you were all hearing about the news on the situation of COVID-19, but specifically about this concern um, for staffing of the anesthesia teams. And as the outbreak increases, how much do they need to be mindful of the way that they create their teams such that uh, they can minimize their risk of infecting themselves? So our idea was to look at how to minimize the number of anesthesiologists that would be unavailable at any one time. And this, of course, would be like a supplemental policy in addition to other infection control protocols that healthcare providers will already be accounting for. So I'm going to put a lot of credit to my PhD student, Vishnu Prabhu, who's on the call as well, for being able to quickly respond and do some modeling of a number of cases that I'm going to share here today, and maybe have a few minutes we can talk about the modeling. But this is a layout of what we were looking at. They've got 6 facilities. Facility 1 is their main hospital, doing a majority of the support for the for their health system. But then you can kind of see there's smaller facilities, but the anesthesiologists can still make their way from one facility to another. Our approach was to take an agent-based simulation, to build an agent-based simulation model. And the idea would be that the anesthesiologists were the agents, as well as hospitals, because the hospitals would interact with the anesthesiologists in terms of knowing which anesthesiologist would be associated with a hospital and how often would they be coming into contact with other anesthesiologists in their group. So, and we made an assumption, which I'll step through some of those, that the shifts would get updated every week. We had a few different ways to initiate what would be the starting conditions for the infection level, and that these models were built and run for basically a 3-month horizon. So I'm providing one just screenshot of the model view of a state chart for what the anesthesiologist would look like going through the system. And so I'm only going to touch on the highlights. If you're up in this yellow box, these are the anesthesiologists that are working in the hospital and susceptible. There are a few different ways that they could make their way into that kind of bigger white box that contains a few of the other ones inside, but all of that is basically those that are infected. But the normal flow from this yellow is susceptible box is that they'll go into the green box that shows that they've been exposed, but not yet infectious. This is a standard SEIR type of model, susceptible, exposed, infectious, and recovered down at the bottom. But what we're doing is each one of those anesthesiologists has is working with other anesthesiologists side by side within their group. And so when they're working on a team, then they could be coming into contact and potentially infecting their colleagues. And so really we have this breakdown in the middle with the brown and the red boxes on when somebody's infected, they're either going to be asymptomatic or symptomatic. So asymptomatic is the brown box and the red is symptomatic. So we can address the ones in the red box very quickly, but it's the ones in the brown box that we're not so sure about. And that's going to then rely on how often does the hospital test. So how long do we let those potentially infected anesthesiologists work before they get tested, and we can pull them out of the system, so that basically they're infecting others when they're in the brown and red boxes. But if we can get them out of the system and over into quarantine, that's what the boxes below there, the yellowish tinted boxes, are doing. The infection detected, the waiting for test, and the quarantine. So those are all places where they could be removed from being in the front line and working with patients. As I said, we have a number of assumptions that we had to make. Many of these, of course, were vetted with our collaborator at the hospital, but then an equal number of these were taken from a various number of documents that have come out online of just things that we know about COVID-19. So a couple of the key things that we wanted to investigate, and this is some of the toughest ones, are the whole thing about transmission rate. And on top of that, specific to anesthesiologists, that's a tougher one to do. So that's probably one of our bigger assumptions, and we don't have a lot of data on that. So then it's a matter of how many times will the anesthesiologist interact with each other. We also have on the patient side, as the anesthesiologists are working with the patients, there's going to be a transmission rate there from the patient. But what our collaborator was thinking is, in general, they're actually going to be more careful with the patients than they are with each other. So his worry is that the staff members, if somebody were to get infected, that there was more danger in it spreading across their colleagues, where they may not always be using the same protocols and being as careful. So some of these other ones, I'm not going to get into step by step through these, but because we're going to illustrate a few of the important ones as we move into the next pieces of the presentation. So this is the key piece that we were looking at. Different options for staff scheduling. So the top one is called inter-hospital mixing, and this is the baseline where we allowed the policy to exist as it is today. They can work at any facility, and they can switch groups, but you stay in the same group or facility for 1 week at a time. Intergroup mixing would mean that within the facility, some of the facilities have more than one group because they're large enough. So you can mix across the groups, but you never mix to another facility. And then we have the most restrictive, which is no mixing. So you stay in a specific group over the entire horizon. So graphically, this is kind of how it looks. And you can see that we have the outer circles representing the 6 facilities. So we have 1, 2, 3, and 4 on the outer side and outside, and then 5 and 6 in the middle. And then you see facilities 1, 2, 3, and 4 are actually large enough where they have more than one group. So this is similar to the very early slide that I'd shown. And so the arrows just represent the mixing that can be done. So intergroup mixing within a facility are the solid lines, and the dashed ones are across facilities. And we also then looked at several cases. So the cases 1 and 2 are basically saying once infected, the anesthesiologist will then either be immune for the entire 90 days or only for 14 days. And in both of those cases, we're turning off patient transmissions because we're just trying to see what's the effect of the anesthesia transmission itself. And then cases 3 and 4, we turn the patient transmission back on. So that kind of sets everything up to then show some results. And if for one base case that we looked at, we started with 3 anesthesiologists that were infected. And we're talking about a total of 43 in the entire group across those facilities. And you can see the inter-hospital group mixing, intergroup, and then no mixing are the 3 major headings across the top. And the if we want to look at average number infected, for example, let's look at the case where they're immune. Once infected, they're immune the rest of the horizon, and there's no patient transmissions, so it's just the anesthesiologist transmission. That's case 1. So average infected is 4. Intergroup mixing, it's 3.1, and no mixing, it's 2.4. So on average, 1.5 anesthesiologists fewer are infected in the no mixing option. As you compare that like to case 3, because case 3 would be the other one where there's immunity, but we've turned back on the patient transmission rate. This goes up to 7.4 infected, down to 6.1 for no mixing. So a similar increase, decrease, about 1.5. Comparing cases 2 to 4, you'll see in case, and this is the situation where they're immune for only 14 days and they go back into the rotation and are potentially susceptible again. We have a comparison of 4.7 down to 2.4. So now it's a little over 2 person reduction on, and a little less in case 4. So it gives you a sense of the change. So that in general, I don't think the changes were that high, at least in the cases that we ran, because you have to remember, so much depends on the infectivity rate. Another interesting point is, let's look at it graphically over time. When are those anesthesia team members not available? So remember, we start with 3 infected at the beginning. And so this is representing days of the simulation. So we get, all of them ramping up during the first few weeks. And these 3 cases that are lower are all for case 2. And if you remember, so case 2 is where patient transmission is not part of it. Case 4 includes patient transmission. So this is without patient transmission, and this is with patient transmission. And you can see the 3 levels as expected, going from the top of the 3 lines in each group would be the inter-hospital mixing, down to the lower line, which would be the no mixing. So this has been our first cut at addressing this to our collaborator at the hospital. I know I'm kind of getting close to the end of my time, so I've just got a couple more graphics to share. We did the same kind of test with only 1 anesthesiologist infected at some of the smaller facilities. Those numbers weren't that much different, just basically smaller in their quantity. If we look at what happens if we double the transmission rate. So now the physician transmission rate went up to 0.6 instead of 0.3%. And we don't have significant jumps, but If I look at the very bottom row, like case 4, there we're able to have the number of infected reduced by a little under 2. In the bottom case, it's more like 3.5 that we were able to reduce it by. So, I mean, as you grow that transmission rate, you're going to have more issues. We did the same thing graphing these two out. So the graph on the left is the one that we looked at before, and then the graph on the right is the new one when you have the transmission rate doubled. So I think, you know, that's where I'm going to stop because I want, in the interest of time, and want to make sure everybody has a chance. This coincidentally was able to get submitted to the Winter Simulation Conference just in time. So we're hopeful to get some good reviews and just be able to get it out there like we all want to do, trying to share the work that we're doing. And I don't know if there's any time for questions now. I don't know if you want me to stop sharing.
Yeah, if there are any questions, I think we have a little bit of time before we move on to the next one. I think it's great work. Thank you again so much for sharing.
Absolutely. And again, you know, probably the interest of time Vishnu is quietly listening, but, you know, I will give all the credit because while I helped direct the work and you know, Vishnu executed, and he really did a good job.
That's great. Yeah, so if we have any questions, feel free to either comment in the chat, you can raise your hand, we'll unmute you, you can unmute yourself, or we have included Kevin's email in the presentation and we'll be sending that out after this.
All right. Well, I've passed the presentation over to Katie. So you can go ahead and start sharing. It's the third bubble from the left. It's got the little arrow pointing up on it for share content. There we go.
Okay, can y'all see?
Yep.
Yes, okay, we'll see what happens when I try to put it in a slideshow mode. Sorry. I think, are y'all seeing the slideshow mode or the editing mode?
The editing mode.
Yeah, that's what I thought. I'm gonna try to move. 1 second. Sorry, technical difficulties.
Don't worry about it.
Okay, is that better?
Yes.
Okay. So in the interest of time, I will get going, but my name is Katie Smith, and I am presenting on evaluating COVID-19 capacity models for health systems, and I am at Emory Healthcare. And so going through, no, that didn't. Oh, sorry. So going through, I'll go through an introduction, background, my general approach, and then an example and next steps. I'm going to be focusing really on my method for evaluating these models instead of what I actually evaluated them as, because the focus really is on what's useful to you and your organization, and that may not be the same as what's useful to me and my organization. So I'm not going to go through all of this, but one thing I wanted to point out is that I am not an expert in epidemiological models. I am an industrial and systems engineer like a lot of you. So I'm approaching this from an industrial and systems engineering background and not, you know, an epidemiological background. So just wanted to make that point. And for those of you who aren't familiar with Emory Healthcare, we're an academic medical institution or a system, and we have 11 hospitals, over 2,000 beds across 11 different counties, our service area is across 11 different counties that have different population makeups, different kind of health status and things like that. So we're looking at kind of a complicated problem. And speaking about what that problem is, there are a lot of COVID-19 hospital capacity models out there right now. This isn't even a full list, I would guess, and that number is growing substantially. And so how do you kind of determine which model or models will be the most useful to your organization? And so I got tasked with this question on April 6th. and they wanted feedback on April 11th. So or April 10th, I had 4 days to come up with that answer. And so the question that spawned for me was also, how do I determine that? And then how do I convey the results so they are useful and easy to understand for leadership to get the most use out of it. So that's kind of what I'm going to be explaining my process, kind of trying to answer these questions. So my general approach, I say, is about 6 steps, but each step has a bunch of sub-steps. And so the first one is, what is the goal of the model? What information, whoever it is that you're giving that information to. For me, it's leadership at the health systems. What information do they want, and what decisions are they trying to make with the information from the models? I think that is those are the 2 things that I think are really important. Everything's moving on after that stems from what the answers to those questions are, which is why I said that it's critical that what your organization is like, what the questions are trying to answer, determines everything else. And then next, evaluate the candidate models. And I'll go over this in more detail, but basically picking the models you're going to choose from, the list, like I said, is ever growing. You eventually probably can't do them all unless you have a really large team working on this. So pick the ones you think are best based on a quick overview or that people have asked for, and then assess the different components of the models, and then run the models under inputs and compare. And then what I think is the most important part of this step is assessing whether or not you understand why the results are what they are. When I change inputs, does it make sense to me why the inputs or the estimates came out the way they were? Because if they don't make sense to me, then that suggests to me that I don't understand something, whether it's something about the model, something about the inputs, something about the estimates. And when I don't understand, it's going to be really hard for me to convey that knowledge on to someone else. And so that means I may have to go back and reevaluate, or maybe at some point I just decide this model is not useful to me personally due to something, and then move on. And then the next is to provide that evaluation to leadership for the predictions. So the way I went about it is I showed the different predictions under our data for the different models I was evaluating, and then the context that I had around the different predictions about the assumptions, and kind of a high-level overview of their different attributes. I made like a little table with check marks so that the ones that had the more check marks as positive attributes for what we were looking for, kind of made sense to choose that, and then proposed the models that we would look at and the workflow. And then that leads to, so I provided that evaluation, but now I'm also consistently updating the models and providing those assessments to leadership as well. And in order to do that, I have to gather new information regularly. Have the goals in our organization changed? And that did happen. When I started, we were only looking at the COVID population. Now that we're starting to ramp back elective procedures up somewhat, now we're looking at the entire population. So that actually did lead to changing the model I was providing them updates on. Updating the data from a hospital, county, and state level. The models are being updated consistently. I'm sure a lot of you are familiar with the IHME model, and on Monday it went through a substantial change. Basically the whole structure changed, the estimates they were using changed, and so that, taking the time to understand why is it different, what has changed, and applying any new context that's needed. And then trying to keep up to date with new models coming out. I will be the first to admit that this is not something I have done very well. There's a lot, and sometimes you just have to say, okay, we're just going to go with what we're working with. But as new information, and I know there's particularly starting to be agent-based models starting to come out, that it's important to kind of keep an eye on what is happening. And then, so I'll go over this one a little more in detail as well, but providing those updates, like I said, I provide them about 3 times a week. So, and I go through kind of new information and context, overview of the scenarios that I chose to run that time, what those results were, and then graphs of estimates. And the 2, I think, most important components of that are what have I learned, what has come out, what's new since the previous update, and then the new results versus and the context around them that usually is related to what that new information is. And then I repeat steps 4 and 5 all the time. And again, I know that's a lot of information and high level, and I'll go through a little bit more in detail now, the evaluating the models approach. And one thing to keep in mind, I know a lot of you have heard this, but I think it's important all the time when I talk about models is to remember that they're all wrong. When you're modeling something, it's never gonna be 100% correct, but some are useful and some are more useful than others. So as I move into talking more in detail about evaluating these, I'm not suggesting that some are right and some are wrong. It's just that in our context, some are more useful than others. So this is kind of, I know you can't read it, it's just to kind of see. My first step was to create a giant table with the different models and the different information about them. And so now I'll go through what that information was. So the first most important thing is what estimators is the model actually predicting. That should line up with what the information that whoever the decision maker is wants, either directly or you can interpolate it from. So for example, if PPE is what they want to know and you know the burn rate, then you can extrapolate the PPE based on the census. But if you need to know census and all it gives you is number of people infected in your region, that might not be as useful. And then how is the model actually predicting these estimators? And I think there are kind of 3 main components to that. What user inputs are required? So what are you inputting either from the state or a county or a hospital level? Typically, what is your current census? What is the infection rate around your area? Things like that. Also, what controls are being used? What in the model are numbers and it's heavily related to C as well, what assumptions are being made, but what can I not control that's impacting the estimates? So those are some critical components because really I think my role is that I'm trying to add the value by saying, okay, I collected these are the assumptions, but these are how I think those assumptions might impact the results. Whether it's these assumptions are optimistic or pessimistic, it'll have a big impact or a small impact. And obviously this is a very hard question to answer, but I think it's particularly hard for people who don't have any modeling experience. So I think this is kind of where I add the most value. And I try to make it very clear that these are all, when we get to this point, it's opinion, but usually I try to find other sources and show that is not necessary. I'm pulling their assumptions from what they've given me, and then I'm trying to understand. And then that relates to what are the limitations of the model, which is directly related to what is the goal. A limitation for me and Emory and what our goal is may not be the same for you and your hospital. And so kind of, again, everything really goes back to what is the goal. And that's the same thing for positive attributes. A positive attribute being, oh, it does estimate PPE or something. Even if I can get it a different way, it might be easier if it does it for me. And then the next step, which is again another critical part, is using the same inputs for all the models that I'm evaluating and comparing the results. Using actual data, also doing sensitivity analysis, and like I talked about on the last slide, do I understand why the results are what they are? When I change things, does the model do what I expect? And then if it doesn't, I need to go back and reevaluate. And if it does, that implies to me that I have a pretty good understanding of what's going on. And so I took all of this information to then provide what became my overall opinion, I guess, or a recommendation. And so now I'll give an example of an evaluation I did on a model. And again, it's all related back, to us. So all of it may not be the same for you, which is why I didn't share all of them. This is just to kind of go through and give an example through the process. So the model is the University of Pennsylvania model. It's a really good model. It estimates different things, COVID admissions, as well as the people in your catchment region who might be susceptible, infected, or recovered. A bunch of different input parameters. I highlighted the things that I thought were most important. One being that this is a model that takes into account in your system or hospital the date of the first hospitalized case. So that kind of combined with whatever the doubling rate or growth rate is, kind of where you started on the curve and kind of draws the curve out from there. Some controls and assumptions. It utilizes estimates from other locations. I couldn't immediately find what locations it was using it from, so I couldn't kind of give my context around it. Like if that data was from Wuhan versus somewhere else in the United States, that's very different because, very different types of social distancing or different types of population. So that is really helpful to understand. I couldn't find it for this. That doesn't mean it's not there. Like I said, I pulled this together in about 4 days, so I could have missed things. Also, I put in some advantages that related to the date of first hospitalized case. There are multiple ways that the model kind of can calculate what your R naught or infection rate is. And I think that's a really strong component. We're also using kind of a data platform that can join different sources of different data, and the UPenn model actually isn't in that platform, and so that's a huge advantage for us when we're looking at comparing how it's working under different scenarios or over time. And some limitations have to do with what it does and doesn't incorporate variability into. Also, everyone being equally likely to either move from susceptible to infected, or even stages in the hospital from a med-surg bed to an ICU bed. When we know that's not necessarily true, but a lot of models kind of take the same assumption. It's just, again, it's not necessarily a bad thing. It's just something to keep in mind when evaluating. And then what I highlighted in red, that it doesn't incorporate non-COVID census, that was with the purpose, I highlighted it differently because that's a limitation over time. When we weren't looking at non-COVID census, it wasn't a limitation, but now that our goals have changed, it has become a limitation because this is a fluid process. Things are changing, and so you have to be flexible. So that, again, that's just like an example of kind of how I approached for one model. But in the interest of time, I'm going to move on to talking about giving a little detail about the updates that I provide and what I think is important. And so when I've updated the model with new data or I've learned things, again, I said kind of a critical component to these updates is what are the new information and context, what has changed since last time, whether the models themselves updated, like I sent out like on Monday when the IHME model changed a lot, or new models. Again, like when we changed our goal, I was using a model that only predicted COVID census, and now we need to combine that with non-COVID census. So we had to use combine our models in some way. Also, new data. What are we learning? Like, for example, literally today, I just saw that they're looking at the percentage of people who are willing to wear masks out in public across the states, and combined with some results from New York's antibody testing saying that healthcare workers are testing at a lower rate than non-healthcare workers, kind of suggesting that PPE usage is important, which is good, and we already kind of knew, but that is new context that we might be able to leverage in our models. Also, what have we seen at Emory the past few days that might change scenarios or might change inputs? Then scenarios. We looked a lot about social distancing, especially as Georgia was pretty much the first state to really relax those. That's been a big component recently. And then kind of a summary of the main takeaways, what the new estimates are, any important context, and then my interpretation of them, and then the images. So I kind of provided, an executive summary and then more information. So I know that was a lot of information really quick, and I want to make sure that Jordan has time as well, but we are looking at new things as well that I haven't presented. We're trying to answer some other questions, like how is Atlanta performing in comparison to the whole state? what's the impact of social distancing mandates previously, and how do we think the relaxing of those mandates will impact? Also, what were the historical predictions of these models compared to the realized data? I'm working on that as well. There are lots of other questions that that are being worked on, but those are the ones that I'm focusing on. A lot of people have helped, different people at different levels of the organization pulling data, or even just giving me the opportunity to work on this, as well as all the people working on models. Like I said, is not an exhaustive list, but we really appreciate it. I didn't have time. We didn't have the time or resources to build our own, and with so many out there, I didn't think it was necessary. But so thanks to everybody. And if there is time, if anybody has any questions, and I also put my email, if you're working on this or someone at your organization is working on this, I definitely am open to collaboration, because there's a lot out there, a lot of information that can be missed.
Yeah. And it looks like Katie in the chat, Dr. Benyon said it was a great summary. I wonder if experimental design, factorials DOE, could be used to help inform the question of what assumptions are model X most sensitive to.
Yeah, I think that's definitely a great point. And I actually have Dr. Benyon's model is one that we are using. I know a lot of you are familiar with that because he presented. And that's definitely a great point. I think as moving forward and getting out of crisis mode, I think that would be a great thing to pull together.
Okay. Any other questions before we move on to Jordan? Thank you so much, Katie, for presenting. That was great.
No problem. Thanks for having me.
This is Jordan. This isn't a question for Katie, but a comment on Katie's presentation. I really enjoyed that table at the beginning. I think having done a lot of now COVID modeling, and unfortunately having the resources to build our own, you summarized the steps and like the challenges at each step really well. It was just a great table. One thing I've bemoaned while I've been looking at all the modeling and publications about models that are going out is I think a lot of people, and many of these are epidemiological modelers, are missing some of the discipline around model development. They're seeing finally an application for the SEIR models, but they don't have the training in using and choosing between multiple models the way engineers do. They know SEIR models. And so many SEIR models are being used for the wrong thing. I mean, the UPenn model is an example that it's built on an SEIR model, but it's trying to give discrete advice on how many beds you need, and it's just not built for that, and it's not accurate. It might be accurate in the long run, but not on a week-to-week basis, while IHME has been super accurate as a statistical model, and can't take into account future outbreaks because it's only fitting to the current outbreak, except now their whole new their new thing has an SEIR added to it. But it's different models for different purposes. And Katie, I think you just did a great job expressing that. So well done.
Thank you. And yeah, I did want to make, I don't know if I made it clear, but we are to that point, because different models have different abilities or are designed for different things. We're using multiple, and I think that's the best approach. And then sometimes the context I provide is, I think this is something we could consider a worst case scenario versus a short, best case scenario, or long term versus short term, and things like that. And I think that's really important context as well. So definitely thank you for sharing.
Great. All right. So I'm going to figure out how I share my screen here, and it's giving me a bunch of options. Let's see.
It's the third one from the left. It's the arrow up. Yep.
Yeah.
Got it.
How's this? Are you seeing some beautiful curves here? All right. Make sure your kids aren't watching. So we've got, I present a little bit on our modeling efforts at the first think tank thing. Oh, I should introduce myself in case people don't know me. I'm Jordan Peck. I'm the Senior Director of the Maine Health Center for Performance Improvement. Maine Health is a system of 8 hospitals and all their outpatient practices and specialty clinics up in southern Maine. And like everyone, we're trying to figure out how to deal with COVID. Maine has been very fortunate that um, our governor was able to, and government was able to jump on social distancing very quickly when Massachusetts started to have a breakout in Boston. And so we have not, there was a very short period of exponential growth, but it got cut off pretty quickly. And so now as we sit and we say, well, you know, COVID's here to stay. We know that we're going to be, you know, going to need to open up services eventually. Their elective procedures were canceled, but over time, elective procedures become emergent procedures. You know, some of these health issues can't be ignored forever. And so what do? We can't just keep our hospitals empty for a COVID epidemic that hasn't actually struck us. And so our CEO came to me and said, "Hey, Jordan, you were doing all this forecasting model. What tools exist for surveillance of the ongoing outbreak?" He recognized, as Katie mentioned, using the multi-model. One of all the SEIR models were saying there would be another outbreak sometime this fall as schools open up and as restrictions get loosened. How do we know, knowing that we're never going to get the number of new cases to zero? How do we know when we are in the midst of another complete outbreak, or whether, you know, as over the course of the summer, as cases rise and fall in a variable manner, whether it's just noise? So how do we distinguish signal from the noise? And of course, like many of you, my first response was to say, let's do control charts. Now, I will say there are more fancy epidemiological methods for tracking ongoing outbreaks, and that's called, you know, it's contact tracing. And so the idea is, of course, that when somebody tests positive, then going and seeing how many people they came in contact with and testing those people and so on. And then at some point, if you find everyone's testing positive along an expanding chain of people, you know you've got an outbreak, versus if it cuts off, you don't. And so they rapidly calculate the R0 for that disease. And if it's growing high enough, they will become you know, announce it as an outbreak. But since we don't, as a health system, we don't have that contact tracing capability, we wanted something to track what was going on, and the state does publish its measures, and we have a multi-specialty laboratory that's doing a lot of our testing. So we had some data and we wanted to look at it. So I don't have slides, but I did want to show you some of what we're seeing. And first of all, what I used was what I'm showing on my screen is my Power BI. And it was something that I used when I was generating my predictive models using Excel. I was then able to show them on a you know, on a graph here, so that leaders across our system could log in and take a look at where we are versus where we're forecasted to be, which has been pretty cool. And what's been most effective about it is my statistical forecasts were less extreme than some of the epidemiological SEIR ones. And so when everybody was panicking, I was saying, you know, we're just not seeing it. Everyone's freaking out, but we're just not seeing those volumes. And it helped people be a little bit more level-headed in their decision making. And so now we're moving to, you know, the models are going the way they're going, but now we're saying we're going to open up some beds. We want to start doing some elective procedures. How do we know when to stop when we're on the verge of another outbreak? And so here's the control chart for 30 days of Maine new cases in the state of Maine. And I'm using this free download from in Power BI. You can go to like import from marketplace and just search apps that people have developed. This one has a 30-day trial that I've got 8 days left on. And it's actually really cool because it recalculates the control limits and has the signal generators. You can see the red dots. This one is an X bar chart. They had a couple of other options, not all the options. And so we are going to move to using R for generating our control charts. But just to get things going and to show leaders what this stuff was capable of, this was a great quick way. And again, something I could upload to a website so that leaders across our system could go on there and play with it. So, as you know, as engineers or engineer adjacent, having a cool model is one thing. Making it accessible to people to play with, to understand the dynamics, to make it something that they feel like they can read is a whole nother level. And so it's been a cool tool. The other thing that is really cool about having it integrated with Power BI is it's got a filter. So I can choose a specific county and it recalculates the control chart for that county. And I can slide the date filter and it will recalculate the control chart depending on the date. So it's a pretty sweet tool, and it was really fast to put together, and made me look really good. So that's something. So what you can see here, and I just exchanged some emails with Dr. Benian about this. The value of the control chart, from my perspective, is I think that control charts offer a lot of value for ongoing monitoring when you're not keeping your eye on the ball all the time. Right, some measure that you care about, and you're just, there's going to be noise, and you want to just have your attention called to it when there's a signal. Similarly, there's value, of course, when you've made a change and you want to see whether there's statistical significance in terms of your improvement. But for a monitoring perspective, it's about that trigger. And we have a lot of population health people that jump on outbreaks when they happen. A nursing home, or right now at one of our food processing facilities, there was an outbreak. And so what you could see, this last dot on the right, there was an outbreak yesterday at Barber Foods, and there was this jump. It might not be the updated data. It did come back down again. So today it's much better than. Refresh the data, see if it shows you that. There you go. So it came back down today, and people are saying, oh, well, maybe we're okay. And actually, if we were to look at Cumberland County, maybe we are. Cumberland had jumped up where Barber Foods is located, and it came back down today. But actually, if we look at Androscoggin, we had a pattern of days that we were above the average number of new cases per day. And that suggests that there's something else going on there, possibly something else. Yes, here's the outbreak, and we're seeing that, but we had days of growth before that. And yes, now it's back down, but we're still in it, have above average growth today. So something's going on in Androscoggin that maybe the people who are tracking the big outbreaks might be missing the smaller signal. And so what's really cool is I know engineers across the world have been trying to get healthcare administrators to look at control charts for the longest time. And this is getting attention right at the very top. The CEO of our health system emails me every day and says, I can't wait to see today's control chart. So that's been super cool from an engineering perspective. And, so anyone who knows things about control charts are seeing, hey, you've got a negative control limit there. You're never going to have negative growth of new COVID cases. And that's because this is an X-bar chart. It uses a normal distribution. We're going to be transitioning to using a C chart, which uses a Poisson distribution. And so, this is what that looks like in R. And, unfortunately, this is less dynamic and less, less user-friendly in terms of how pretty it is. But now that our leadership has been looking at this for the last 20 days, they're getting comfortable with it. And I think if I throw a more complex chart at them, they'll actually be okay with it. So we're going to be, thanks to Mohit, who's an engineer on our team, and Linda Adwan, who's on the call as well, as an engineer on our team, and did a lot of research on what IHI has been putting out to help us pick which were the right control charts for us to use and the right way to display it. We've got this county data, and Mohit's programmed this in R that it's going to generate a PDF that we send out every day with each of the counties. And similarly, we have our lab, it's called Nordex, which allows us to use a U chart where every day we know exactly how many tests they ran and how many tests came out positive. And so unlike the other ones where you have sort of a constant number of people in the county who might get the disease, and some of them are positive and some aren't, in the testing situation, you have a certain, batch of tests, and some get positive, so the control limits will change as they go. So if you Google search COVID-19 IHI control charts, they're putting out their own tools for people to use. But also if you Google search R control chart codes, I mean, all the code is written there for you. So if this is something, as your local communities eventually go like Maine towards being in more sustainment mode, I highly recommend giving this approach a try. That's that, and I don't know if there were any chats or questions. I'm happy to answer.
This is really great stuff, Jordan. Thanks for sharing. I don't see anything in the chat, but again, we're going to have Jordan's contact information in the PDF we send out afterwards, so you can definitely get a hold of him there if you do have specific questions as well.
I think this is really great, Jordan. This is Katie again. We've been working, kind of like I said, what we're trying to look at right now is how our group or our area is responding compared to all of Georgia. And so something like this, a control chart, I think would be really useful.
Thanks.
All right. So it looks like, I guess, Dr. Bennion, it looks like, has a couple things to say. Important considerations are, one, being OOC above any upper control limit is one thing. What upper clinical limit is important to start to distance again?
It's interesting.
And that's something that our group, we our CMO and it's interesting. Our CMO, our engineers, and our accountant CEO all have very different interpretations of what we need to look for. So obviously, our accountants are chomping at the bit to get us back in business. Our CMO is being a little bit more. She wants very tight, sensitive control limits, and she wants not to be as strict about the rules. Like, instead of waiting for 4 points above 2 standard deviations, as long as we have 2, like, we should start, coming up with ways to cancel cases. And then, of course, we have a lot of doctors on the front line who are chomping at the bit to get to work and are blaming the accountants for closing things down. And I'm like, no, it's the CMO. Like, go talk to your own people. And then the engineers are just saying, look, here's the data. You guys go make some decisions. So I don't think there is a definite right answer. I do think that we're being cautious, and that the health of the population and of our staff is of the utmost concern. Similarly, continuing to maintain our PPE is really important. If we open up too much and we start doing more surgical cases, we can start using up PPE really fast. And then if we get hit by a new outbreak, we can be in big trouble.
Okay. Well, I think we'll go ahead and end here. Jordan, thank you. And thanks everyone for participating today. We'll send out the recording on Monday. And if anyone is interested in presenting any of their work, we do have some slots available for next Friday if anyone has any presentations they want to give. So just let Allie and I know.
Thanks, Aaron and Allie.
Yeah. Thanks, everyone.
Thank you.
Appreciate it.